الرحيم. تسجيل يا شباب. اوكي، تسجيل كيف؟
بس دقيقة.
تسجيل يا شباب، هل بدأ التسجيل؟ عبد الرحمن، التسجيل.
ايوه بدأ التسجيل يا دكتور، ما أنا عندي طلع.
إذا كويس. بسم الله الرحمن الرحيم. قال تعالى: وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. وقال رسول الله صلى الله عليه وسلم: ينقطع عمل ابن آدم إلا من ثلاث، ومنها عمل ينتفع به. السلام عليكم ورحمة الله وبركاته. الإخوة الحاضرون جميعا، أحييكم كل باسمه وصفته وموقعه. أرحب بكم في برنامج جديد من برامج الشبكة الدولية للبحث والتعليم المستدام. برنامجنا هذه المرة يستهدف فئة مهمة في مجتمعنا، وهو برنامج للأطباء، برنامج طبيب المقيم المتميز. يستهدف هذا البرنامج الأطباء المقيمين بالدرجة الأولى، ثم طلبة الطب والعلوم الصحية في مختلف المراحل الدراسية. تم اختيار 10 محاضرات عملية تغطي بعض ما يحتاجه الطبيب في إقامته. الهدف الرئيسي لهذا البرنامج هو تعزيز التواصل والتعليم المستمر بين خبرة الأطباء المتحدثين والأطباء الذين هم في بداية مسارهم العلمي. معنا اليوم في هذا البرنامج الإخوة المنظمون للبرنامج، شبكة إسرين. هذا البرنامج أيضا برعاية وزارة الصحة والسكان في اليمن، وبالتعاون مع جامعة العلوم والتكنولوجيا والإخوة أطباء اليمن في المهجر. البرنامج تم بالتنسيق مع هذه المجموعة من الأطباء كبداية للبرنامج رقم 1، وسوف يستمر البرنامج إذا وجد الدعم من قبلكم كحضور وتفاعل واقتراحات. أشكر الأطباء المتحدثون وهم نواة هذا البرنامج. معنا اليوم في حفل الافتتاح كلمات مهمة، نرجو منكم الاستماع لها لما لها من إيقاع مهم في هذا البرنامج وفي البرامج القادمة. سوف نبدأ البرنامج بكلمة الشبكة الدولية للبحث والتعليم المستدام، يلقيها علينا الدكتور عبد الله الشليف. وتفضل دكتور عبد الله، المايك لديك.
السلام عليكم ورحمة الله وبركاته. الصوت واضح؟
نعم واضح.
بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا محمد وعلى آله الطيبين الطاهرين. معالي نائب وزير الصحة العامة والإسكان الدكتور عبد الله دحان، سعادة رئيس جامعة العلوم والتكنولوجيا الأستاذ الدكتور عبد الغني حميد، سعادة رئيس جامعة سيئون الأستاذ الدكتور محمد عاشور، سعادة رئيس أطباء اليمن في المهجر الدكتور حمدي الحكيمي، سعادة رئيس برنامج المقيم المتميز الدكتور مهنا الشيباني، سعادة الأستاذ الدكتور ناصر حيدر المتحدث لهذا اليوم، الحضور الكريم من الأساتذة والأطباء والباحثين في مختلف أنحاء العالم، السلام عليكم ورحمة الله وبركاته. يسعدني ويشرفني أن أكون معكم اليوم رغم المسافات عبر هذا اللقاء العلمي المميز، ممثلا عن الشبكة الدولية للبحث والتعليم المستدام في الجلسة الافتتاحية لبرنامج المقيم المتميز. هذا البرنامج النوعي الذي يجمعنا في فضاء حر ويجمعنا في منصة واحدة ويخدم التعليم المستدام. الحضور الكريم، لقد أثبتت البرامج الإلكترونية قدرتها على تجاوز الحدود الجغرافية وفتحت آفاق أوسع للتعليم والتواصل، وهو ما نلمسه اليوم من خلال هذا الحضور المميز من مختلف الدول، بما يعكس أهمية هذا البرنامج ونجاح فكرته. ومن هذا المنطلق سعت الشبكة الدولية للبحث والتعليم المستدام منذ تأسيسها إلى بناء جسور فاعلة بين الكفاءات اليمنية والعربية في الداخل والخارج، وربطها بالباحثين والعاملين في سوق العمل، إضافة إلى المؤسسات الحكومية وغير الحكومية، إيمانا بأهمية تكامل الجهود وتبادل الخبرات. وخلال فترة وجيزة تمكنت الشبكة الدولية للبحث والتعليم المستدام بفضل الله ثم بجهود كوادرها من تحقيق إنجازات ملموسة، حيث نظمت 9 برامج تدريبية في مجالات متعددة مختلفة، شملت الجوانب البحثية والجوانب الإدارية والجوانب الطبية، إضافة إلى برامج متخصصة في المناخ والبيئة. كما أقامت الشبكة خلال السنتين الماضيتين 59 ندوة علمية في مختلف التخصصات، ونظمت الملتقى الأكاديمي للباحثين اليمنيين في ماليزيا، إلى جانب توقيع 11 اتفاقية تعاون مع جامعات ومؤسسات يمنية ودولية. وخلال العامين الماضيين تم تشكيل المجلس التنفيذي للشبكة، والذي يضم نخبة من الكفاءات اليمنية ذات الخبرة الطويلة في مجالات التعليم والبحث العلمي، إلى جانب أعمالهم الأكاديمية في مختلف الجامعات. ومع توسع الشبكة وتوسع أعمالها، تم إنشاء مجلس سفراء الشبكة الدولية في عدد من الدول والمؤسسات التعليمية. كما تم مؤخرا تشكيل المجلس الاستشاري الذي يضم مقامات علمية من مختلف الدول لدعم مسيرة الشبكة وتوجه أعمالها. الحضور الكريم، في إطار تعزيز دور الشبكة في خدمة الباحثين والأكاديميين، بما يمثل موقع الشبكة منصة علمية متكاملة تجمع الباحثين وتفتح آفاق التعاون بينهم. إن سر قوة الشبكة اليوم هو في الكوادر الذي يديرونها، وكذلك في موقع الشبكة. وأنا أريد أن أركز على هذه النقطة، وعلى كل من يسمعني أتمنى من زيارة الموقع. ومن هنا ندعو جميع الباحثين والأكاديميين إلى إنشاء حساباتهم الشخصية على موقع الشبكة، لما لذلك من أهمية في بناء الهوية العلمية وتعزيز فرص التواصل والتعاون بين الباحثين بعضهم ببعض. كما نحثكم إلى الانضمام إلى المجموعات البحثية. فمؤخرا في الشهر الأخير أو في الشهر الماضي تم إنشاء 42 مجموعة بحثية في مختلف التخصصات على موقع الشبكة، بما يساهم في تعزيز العمل الجماعي وتبادل الخبرات وإنتاج أبحاث نوعية مشتركة. ولمن يرغب في مزيد من التميز، تتيح الشبكة العضوية المدفوعة، والتي تمنح عددا من المزايا، من أبرزها الحصول على شهادة عضوية سنوية معتمدة من الشبكة الدولية، إضافة إلى فرص أوسع في المشاركة والتطوير المهني. ويسعدني أن نشير إلى أن عدد المسجلين في العضوية المبدئية المجانية قد بلغ حتى الآن 4315 عضوا، وهو ما يعكس الثقة المتزايدة في دور الشبكة وأثرها في المجتمع الأكاديمي. وفي هذا المقام تتقدم إدارة الشبكة بالشكر الجزيل والتقدير لكل الأساتذة والدكاترة والكفاءات اليمنية والعربية على تفاعلهم المثمر ودعمهم المستمر. كما لا يفوتني أن أشيد بجهود القائمين على هذا البرنامج، ونتقدم جميعا بالشكر والتقدير لوزارة الصحة العامة والإسكان في رعايتها لهذا البرنامج. وكما نتقدم بالشكر الجزيل على الجهود التي تقوم به جامعة العلوم والتكنولوجيا المركز الرئيس في عدن وكل فروعها في أنحاء الجمهورية. وكذلك نتقدم بالشكر الجزيل لكل الجامعات الموقعة اتفاقية مع الشبكة الدولية، وعلى رأسهم جامعة سيئون التي يمثلها أو يحضر اليوم معنا رئيسها، الذي يمثل نموذجا ناجحا للتعاون المثمر بين الشبكة والمنصات الرقمية وغيرها من الجامعات. ختاما، نؤكد إلى أن الشبكة الدولية للبحث والتعليم المستدام نستمر في دعم هذه المبادرات النوعية وتعزيز الشراكات العلمية التي تتجاوز الحدود وتسهم في بناء الإنسان وتنمية الأوطان. والسلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته.
السلام ورحمة الله. شكرا دكتور عبد الله. وكما تحدثنا أيضا، فإن جامعة العلوم والتكنولوجيا كانت أحد الداعمين لهذا البرنامج، فيسرنا أن يكون لهم كلمة. والمتحدث عن جامعة العلوم والتكنولوجيا الأستاذ الدكتور عبد الغني حميد أحمد، فليتفضل دكتور، المايك لديك، وشاكرين جهودكم مسبقا في دعم هذا البرنامج.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وأصحابه ومن والاه. الأستاذ الدكتور عبد الله دحان، نائب وزير الصحة ونائب وزير الصحة والسكان. الأخ الأستاذ الدكتور عبد الله الشريف، رئيس الشبكة الموحدة للبحث والتعليم المستدام. الأستاذ الدكتور حمدي الحكمي، الأستاذ الدكتور
حكيمي.
الحكيمي، الأستاذ الدكتور مهنا الشيباني، الأستاذ الدكتور ناصر حيدر، الحضور جميعا عبر الزوم. السلام عليكم ورحمة الله وبركاته. يسعدني ويشرفني أن أرحب بكم جميعا حضورا ومشاركين في افتتاح برنامج المقيم المتميز، هذه المبادرة العلمية الرائدة التي تشكل منصة تعليمية متميزة للمقيمين والأطباء الطامحين إلى تطوير قدراتهم الأكاديمية والعلمية. إن تنظيم هذا البرنامج لم يكن ليتحقق لولا الجهود الكبيرة والمتواصلة للشبكة الدولية للبحث والتعليم المستدام، التي نخصها بالشكر والتقدير على رؤيتها العلمية الطموحة وسعيها الحثيث لخلق بيئات تعليمية مستدامة ترتقي بمستوى التعليم الطبي وتسهم في بناء جيل من الأطباء القادرين على مواجهة تحديات المستقبل. كما لا يفوتني أن أعبر عن عميق الامتنان وصدق التقدير لوزارة الصحة والسكان ممثلة بالأستاذ الدكتور عبد الله دحان نائب الوزير على رعايتها الكريمة لهذه الفعالية العلمية وعلى دعمها المتواصل لكل ما يسهم في تعزيز قدرات الكوادر الطبية وتطوير التعليم الطبي في بلادنا في الداخل والخارج. وشكر خاص يتوجه إلى أطباء اليمن بالمهجر الذين يمثلون مصدر إلهام وركيزة أساسية لنقل المعرفة والخبرة ومساهمة فاعلة في خدمة وطنهم، خاصة في هذه الظروف الصعبة التي تتطلب العطاء والمثابرة والالتزام ليظل الوطن نابضا بالأمل رغم كل التحديات. برنامج المقيم المتميز أو المقيم المتميز ليس مجرد سلسلة من المحاضرات العلمية، بل هو تجربة تعليمية متكاملة تهدف إلى بناء جسور المعرفة بين الأكاديميين والواقع العملي، ويقدم محتوى علميا تخصصيا متقدما يغطي كافة المجالات الحيوية التي يحتاجها المقيم في مسيرته الطبية. هذه الفعالية تمنح الفرصة لتوسيع المدارك وتعزيز المهارات السريرية وتطوير التفكير النقدي والقدرة على اتخاذ القرارات الطبية المستندة إلى أفضل الأدلة العلمية. وفي هذا الإطار تتشرف جامعة العلوم التكنولوجية ويسعدها أن تلعب دورا محوريا في إنجاح مثل هذا البرنامج وغيره من البرامج، ليس فقط من خلال توفير البنية الأكاديمية والعلمية المناسبة لطلبتها ومنتسبيها في إنجاح هذا البرنامج وأيضا والمساهمة في إنجاح هذا البرنامج، ليس فقط من خلال توفير البنية الأكاديمية والعلمية المناسبة، بل أيضا عبر تنسيق الأنشطة العلمية المختلفة وتهيئة بيئة تعليمية محفزة تتيح التفاعل المباشر بين المشاركين والمحاضرين، بما يعزز من فرص التعلم والتبادل المعرفي ويرسخ لدى كل مقيم فهما عميقا لمتطلبات الممارسة الطبية الحديثة. إن مشاركة أطباء اليمن في المهجر في هذا البرنامج تجسد معنى الولاء المهني والوطنية العملية، فهم لا يقدمون مجرد محاضرات بل ينقلون خبرات وتجارب ثرية اكتسبوها في أرقى المؤسسات الطبية العالمية، ليصبح للمقيمين في اليمن فرصة استثنائية للتعلم من أفضل المصادر العلمية والعملية. وهذا الدور الحيوي يعكس رسالة واضحة: إن العطاء الطبي لا يعرف حدوداً جغرافية، ولأن الخبرة المتراكمة يمكن أن تصبح جسرا نحو تحسين الرعاية الصحية في وطننا الحبيب. أيها المشاركون الكرام، إن هذا البرنامج يمثل فرصة فريدة لتوسيع الآفاق العلمية وتعميق الفهم الطبي وبناء شبكة علاقات مهنية قوية والارتقاء بالمهارات العملية بما يتوافق مع أعلى معايير الجودة الطبية. لا بد من استغلال كل لحظة من هذه التجربة والمشاركة بحماس وفضول علمي، فالعلم ليس مجرد معرفة نكتسبها بل تجربة نعيشها وسبيل نحو الابتكار والتميز في الحياة المهنية. في الختام، أتمنى لكم جميعا مشاركة مثمرة وتجربة تعليمية ملهمة، وأن يغادر كل مقيم من هذا البرنامج وهو أكثر معرفة وأكثر قدرة على مواجهة التحديات وأكثر إصرارا على رفع مستوى الرعاية الصحية في وطننا الحبيب وأينما كنتم وحللتم. في الختام أقدم الشكر والترحيب بالجميع، وعلى رأسهم أيضا مرة أخرى معالي الأخ نائب الوزير والأخ رئيس المنظمة أو المسؤول عن الشبكة، وأيضا لا أنسى الدكاترة الأفاضل وعلى رأسهم أستاذنا الحبيب الأستاذ الدكتور محمد عاشور الكثيري رئيس جامعة سيئون. أتمنى للجميع التوفيق، والسلام عليكم ورحمة الله وبركاته.
عليكم السلام
عليكم
ورحمة الله
السلام.
وبركاته.
شكرا دكتور عبد الغني، حياك الله. ولا ننسى جامعة العلم والتكنولوجيا ودعمها المستمر. والآن كلمة مهمة من رجل مهم عرف بحبه للعلم وتشجيعه للعلم والعلماء والأطباء. الكل أعتقد تتلمذ على يديه أو عمل معه في مستشفى الثورة أو جامعة صنعاء. معنا كلمة نائب وزير الصحة أستاذ الدكتور عبد الله محمد دحان. طبعا الأستاذ عبد الله دحان نائب وزير الصحة العامة والسكان، أستاذ مساعد الجراحة العامة جامعة صنعاء، استشاري أول جراحة عامة، حاصل على البورد العربي في الجراحة العامة، وحاصل على زمالة كلية الأطباء والجراحين من باكستان، وهو عضو الهيئة العليا والمكتب التنفيذي في المجلس العربي للاختصاصات الصحية. تفضل دكتور عبد الله دحان لإلقاء كلمة في هذا البرنامج، وشكرا لتلبيتك للدعوة. المايك لديك دكتور عبد الله.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على خير خلق الله محمد بن عبد الله وعلى آله وصحبه ومن والاه. بداية أود التعبير عن سعادتي البالغة في المشاركة بهذه الفعالية، موجها الشكر لأصحاب المبادرة في تنظيم وعقد هذه المبادرة، وهي الشبكة الدولية للبحث والتعليم المستدام، وشركائها وهم الأطباء أو أطباء اليمن في المهجر، وكذلك جامعة العلوم والتكنولوجيا في بلدنا الحبيب اليمن، وهي إحدى الجامعات التي استطاعت وخلال فترة قياسية وجيزة أن تبني قاعدة لها وسط الجامعات اليمنية والإقليمية والدولية. وأرحب بالأخوة الأعزاء من جامعة حضرموت ممثلة بالأخ الأستاذ الدكتور محمد الكثيري رئيس الجامعة، وكذلك أرحب بالزملاء الأعزاء المحاضرون أو المحاضرين في هذا البرنامج، ومنهم من أعده أخا وزميلا وصديقا عزيزا مثل الأستاذ الدكتور ناصر حيدر، ومنهم من تشرفت بنقل جزء من معارفي وعلمي المتواضع إليهم عندما كانوا على مقاعد الدراسة في كلية الطب والعلوم الصحية، ومنهم على سبيل المثال الدكتور فتحي هرهرة، ومن الميسرين كما أعتقد الدكتور مهند مطيع، وأيضا الزملاء الذين سأتشرف بمعرفتهم من خلال هذا البرنامج، وهم من بالتأكيد من الزملاء المرموقين في مجالاتهم، وممن يمثلون الحركة الطبية أو الصحية اليمنية بشكل عام داخل اليمن وخارجها، خير تمثيل إن شاء الله. إخوتي الأعزاء، لا أخفيكم بأنه عندما تم التواصل معي من قبل الأخ العزيز دكتور مهنا الشيباني في بادئ الأمر لإعلامي بهذه الفعالية، وهي دورة تدريبية متخصصة ونوعية، ثم تلاه بعد ذلك الأخ العزيز الدكتور عبد الله الشليف رئيس الشبكة أو الرئيس التنفيذي للشبكة، أنني سعدت جدا بأن أحاط علما بهذه الشبكة وأنشطتها وبرامجها المختلفة، وأخص بالذكر هذا البرنامج لما له من أهمية قصوى في تحقيق أهدافنا في وزارة الصحة العامة والسكان من أجل الارتقاء بقدرات ومهارات الأطباء اليمنيين، سواء منهم المقيمون الذين هم منخرطون في مختلف برامج التدريب والتأهيل العالي، أو ممن يقدمون خدماتهم للجمهور في بلادنا وخارج بلادنا. لما لهذه الدورة من أثر أتوقع أن يكون إيجابي للارتفاع بمستوى أدائهم وجودة خدماتهم لمواطنينا ولمواطني الدول الشقيقة والصديقة حيثما كانوا وأينما تواجدوا. أيضا أرحب بالزملاء الأطباء المقيمون أو المقيمين من أبنائنا وبناتنا الذين سيشاركون في هذا البرنامج لأهمية ما يمكن أن يحصلوا عليه من بعض المعارف والمهارات الإضافية التي أتمنى أن تنعكس منهم على خدماتهم المقدمة سواء داخل بلادنا، وهذا ما يعنينا بالدرجة الأساس، أو خارج بلادنا، فالإنسان هو الإنسان أينما وجد وحيثما كان. وبطبيعة مهنتنا واختصاصاتنا فإن خدماتنا توجه للإنسان، ولكن كوني أمثل الحكومة اليمنية ممثلة بوزارة الصحة العامة والسكان، وبحكم موقعي كنائب للوزير فيها، أقول أننا معنيون بالدرجة الأساس برفع مستوى الخدمات المقدمة لأبناء شعبنا في الداخل، وتطوير مهارات وقدرات أبنائنا وبناتنا من الأطباء والطبيبات والكوادر الصحية المختلفة. نحن ندرك أهمية بعض التوجهات العلمية مثل التعليم الطبي المستمر والتطوير المهني المستمر. فإن كنا نستهدف اليوم بالدرجة الأساس المقيمين من الأطباء والكوادر الصحية المختلفة بهذه الدورة، فإن الطلبة المتواجدين على مقاعد الدرس في الجامعات المختلفة سواء داخل اليمن أو خارجها هم أيضا بحاجة للاستزادة بالكثير من المعلومات التي ستنعكس على هذا البرنامج من خلال المحاضرات القيمة التي سيدلي بها إخواننا من المحاضرين في هذه الدورة، تنعكس على مستوى خدماتهم وعلى مستوى أدائهم وقدراتهم ومهاراتهم. لا أريد أن أطيل، لكني أقول أنكم شرفتموني أخوتي الأعزاء بالمشاركة في هذا البرنامج المهم، وإنني على ثقة بأن هذه المبادرة بهذه الفعالية ستكون باكورة تعاون وتنسيق دائمين بإذن الله بيننا وبين الشبكة الدولية للبحث والتعليم المستدام، وكذلك مع الأخوة الأعزاء في الجامعات الحكومية والخاصة. وأخص بالذكر هنا ممن وجدتهم على هذه الشاشة، وهما الأخ العزيز الدكتور عبد الغني حميد رئيس جامعة العلوم والتكنولوجيا، والدكتور العزيز الأستاذ الدكتور محمد عاشور الكثيري، متمنيا لكم جميعا الاستفادة من هذه الدورة ولآفاق التعاون بيننا مزيدا من التطور والارتقاء بما يحقق مصلحة بلادنا وشعبنا وينتقل بالخدمات الصحية المقدمة لأبناء شعبنا في مختلف المؤسسات الصحية ويحقق الأهداف المنشودة من كل ذلك. شكرا جزيلا مرة أخرى، والسلام عليكم ورحمة الله وبركاته.
عليكم السلام. شكرا دكتور عبد الله دحان، فأنت أستاذ
الله.
كبير للجميع إن شاء الله. شكرا لكلمتك وتوجيهاتك، وإن شاء الله نكون عند حسن ظن الوزارة فينا. كلمة للدكتور حمدي قبل أن يطلع فوق الطيارة. الدكتور حمدي الحكيمي، الأمين العام لأطباء اليمن في المهجر. المايك لديك يا دكتور حمدي، الحق قبل ما تطلع الطيارة.
طبعا كان المفترض
دكتور حمدي.
أن كلمته قبل كلمة سعادة النائب، ولكن الدكتور حمدي كان في الجوازات ومسافر.
أيوه.
تفضل دكتور
لا
حمدي.
بأس.
ما فيش المايك يا دكتور، افتح المايك.
حياكم الله. أنا
يلا
الآن في المطار، في مطار أمستردام، يعني يمكن هذا أكبر تمثيل للهجرة أو الأطباء المهاجرين.
أيوه.
فحياكم الله. الفعالية الرائعة هذه المتميزة مع الشريك الفعال والرائع الشبكة الدولية، مثلا في دكتور الشريف ودكتور مهنا، الدينامو المحرك في الشبكة، ومع الشركاء الآخرين الدكاترة الأعزاء من جامعة العلوم والتكنولوجيا. أحدثكم أنا دكتور حمدي الحكيمي، الأمين العام لأطباء اليمن في المهجر، وهي منظمة تأسست في أيام جائحة كورونا، وكان هدفها هو مساعدة الجيش الأبيض في اليمن من أجل أن يكافح هذا الداء وهذه الجائحة. والحمد لله استمر التواصل مع هذه الشبكة الدولية، أو يعني إحنا برضو نعتبر شبكة أو نتورك من الأطباء التي هي عابرة للحدود وعابرة للقارات، واشتغلنا كثير في فعاليات تدريبية وتثقيفية. لكن هذا الجهد المنظم الرائع من الشبكة الدولية لا ينبغي لنا إلا أن نكون يعني مساهمين فيه، لأنه بصراحة عجبني جدا البرنامج اللي هو تدريب الطبيب المقيم، بسبب انه هذه المرحله، مرحله الريزيدنسي في حياه الطبيب المقيم، هي مرحله جدا مهمه يتحدد على اثارها مساره المهني المستقبلي. وبالتالي فاي تواصل، توجيه، جايدنس، ارشاد، حتى تواصل ان شاء الله مع الكوادر الموجوده من اطباء المهجر المئات الموجودين في مختلف دول العالم، ممكن ان يساعد او تكون هذا البرنامج كبدايه لمساعده هذه الكوادر في التدريب، وايضا مساعدتها في تحديد مسارها المهني والحصول احتمال على فرص تدريبيه مهنيه في الخارج، من اجل ان يتاهلوا بشكل افضل. ونتمنى كلنا طبعا ان نعود الى الوطن الحبيب، وان شاء الله اقترب هذا اليوم لكي نساهم في دورنا الحقيقي في تطوير المجال والقطاع الطبي في اليمن، الذي يعاني من مشاكل كثيرة جدا دائما بنتناولها. آخر ندوة تناولنا موضوع التأمين الصحي في اليمن، يعني الواقع والمستقبل. أحب دائما هذه الأفكار الجديدة التي تنعش البيئة الراكدة أحيانا وتلقي فيها حجارة، وجدا رائع عندما يكون الجهد منظم ولديه بروجرام ولديه خطة، كما وجدنا عند الإخوة الرائعين في الشبكة الدولية. شكرا جزيلا لكم، واعذروني على أنه القصر هذا الكلام، لأننا الآن في المطار، وسعيد جدا بأن أستمع للآخرين حتى يأتي موعد الرحلة.
شكرا لك دكتور حمدي، جزاك الله خير. ونرحب بالجميع كل باسمه وصفته. هناك الكثير من القامات العلمية، وأخص هنا بالذكر الدكتورة إيمان علي باصادق، أستاذ طب الأطفال وصحة الطفل، نائبة عميد الدراسات العليا والبحث العلمي في جامعة عدن. نرحب بك دكتورة إيمان. قبل أن نبدأ البرنامج، الآن نعود. هناك تعليمات للأخوة الحضور جميعا، ومن هذه التعليمات هي أن يكون مسجلا في الشبكة حتى يستطيع الحصول على الشهادة. الحضور يجب أن لا يقل عن 80% من محاضرات، يعني لو هن 10 8 محاضرات على الأقل، حتى يستطيع الحصول على الشهادة. وكذلك إغلاق المايكات أثناء حديث المحاضر، وسوف تفتح باب الأسئلة أثناء المحاضرة. هناك نصف ساعة لباب الأسئلة، وتقريبا على حسب كلام المحاضر يمكن المحاضر يفتح باب العملي أو الأسئلة في النص، فهذا على حسب رأي المحاضر. والآن نتوجه إلى محاضرة اليوم، وهي بعنوان An Approach to Predict and Evidence-Based Management. باللغة العربية: منهجية التعامل مع الصدمة لدى الأطفال والعلاج المبني على الأدلة. نبذة بسيطة عن المتحدث ليومنا هذا، دكتور ناصر حيدر، وهو مشرفنا. دكتور ناصر حيدر استشاري أول عناية مركزة وطوارئ الأطفال، حاصل على الزمالة البريطانية في طب الأطفال، وحاصل على البورد العربي والبورد السعودي في طب الأطفال، حاصل على الزمالة في طب العناية الحرجة للأطفال، حاصل على ماجستير في التعليم الطبي، حاصل على دبلوم إدارة مستشفيات، خبير في جودة الرعاية الصحية. تفضل معنا دكتور ناصر، المايك لديك، وجزاك الله خير على قبولك المشاركة معنا. يمكن أن
بسم الله
تشارك
الرحمن الرحيم.
الشرائح وتتفضل.
نستغل الوقت في رفع هل واضحة
نعم واضح
الصورة
دكتور، يمكن تبدأ.
والصوت والشريحة؟
واضح والشريحة والصوت واضح.
تمام. بداية شكرا كثيرا رعاة البرنامج والمنظمين، كل باسمه وصفته، وأخص الأخ مهنا لصبره في المتابعة، وأيضا محظوظ بأني أول المشاركين في هذا البرنامج، المقدم المحاضرات. والحظ أتى من رؤيتي لأخ صديق وعزيز الدكتور عبد الله دحان نائب وزير الصحة، أيضا رئيس الجامعة الدكتور عبد الغني. البرنامج مهم، وهو ليس بمثابة أستاذ ومتعلم، وإنما لتبادل الخبرات والتجارب. فأحيانا قد يكون الشخص وهو في عمل ما بمستوى تعليمي أقل، لكن خبرته من الواقع العملي لا شك أنها مثرية مفيدة وتلهم الآخرين في مستقبلهم العلمي أيضا والأبحاث الطبية. فهو مهم أن يكون التواصل هذا بيننا وبين الإخوة الزملاء في الوطن الكبير اليمن. العنوان المحاضرة كما ترون هو Approach for Pediatric Shock Recognition and Management. I have no any relevant financial or non-financial benefit to disclose. The objectives of this presentation will be as follows. That means anyone of the audience will be able to differentiate the types of shock in pediatric patients using history, signs, and targeted initial investigations. That means we know that in certain areas, rural areas, and even in some hospitals, maybe they don't have the immediate facilities to help the patient. So how can they manage the patient with the simple and initial clinical information? Then how to implement the current evidence-based management protocol for the stabilization of these patients, and monitoring and reassessing hemodynamic status to recognize the response to the treatment, and adjusting, of course, the treatment according to the response. This introduction, it emphasizes how significant this problem, pediatric shock. It is important everywhere, but it is more important in certain parts of the world. Just see here, 2% of all pediatric emergency admissions or visits, they die due to shock. And that means around 10 million child die worldwide from shock. And you will see later, most of them because of simple problem like gastroenteritis, dehydration. And you will come to that in detail. Here, this map indicates the distribution of these mortalities worldwide. You see Yemen here, we have 20-25% of patient or pediatric patient with sepsis, they die. From the age point of view, the highest mortality is those below 5 years of age. And if you come to the pediatric, of course, up to 18 years in certain systems, and I think in our country up to 14, and they represent the majority of death from sepsis and shock state due to different causes. When you come to the definition of shock, you will find a lot of references and definition, different references. For example, acute energy failure because of no oxygen, no glucose to the tissues. Other, they said no generalized cellular hypoxia. They went a little bit deeper to the cell. Other, they went even deeper to the mitochondria. They say mitochondrial failure at the cell level. However, the best approach and definition, or more common, is this. It is an imbalance between the demand and the supply. How much the patient is able to get oxygen and nutrients and glucose, and how much his tissue in need for that. So it is sort of supply and demand. That means how much oxygen delivery and how much oxygen consumption. And that is maybe the general and wider term of definitions. It is very important because we are talking to colleagues from different parts of the country, and they have different resources at different levels. So I aimed to bring the WHO guidelines in the management of shock compared, of course, to the management of shock in the high resource countries. Say, for example, in WHO resource limited setting, that means, let us to be clear, what does a resource limited setting in this particular subject, in the shock management? It means in these countries, there is no or very limited intensive care unit care. That means the care of in the ICU for pediatric patient either not existing or if exist is not that optimal. So this patient, a special group of patient, if that surface is not existing, then there's some consideration, what are we going to do for this patient? We'll come later to explain it more. The first thing in this definition in the resource limited setting, they avoided the terminology which is known by the PALS, APLS in the advanced country, in the well-developed country, which is the compensated shock. No, here they call circulatory impairment. So what is circulatory impairment? It means cold extremities, capillary fill time more than 3 seconds, and weak, fast pulse. These three criteria, it represent the circulatory impairment in this definition. If the patient is having 1 or 2 plus fever, it goes to sepsis, and we'll come to that in more detail. So this is equivalent to the pulse definitions as compensated shock. Now, if the patient have all the 3 of these instead of 1 or 2, like the patient have cold extremities, capillary fill time prolonged more than 3 seconds, and weak rapid pulse. Here, in this case, the patient is having septic shock. Or if you, in your facility, you can easily measure the blood pressure. If the patient is 1 year and systolic blood pressure is than 50, this is in septic shock, or shock if there is no fever. 1 to 5 less than 60 and more than 5 less than 70. You see here, it is very bizarre numbers. If you compare it to the decompensated shock, which is the PALS recommendation. PALS here, less than 1 month, less than 60, less than 1 year, less than 70 millimeter mercury, 1 to 10 years, 70 plus, 2 multiplied by age, and more than 10 years, less than 90, similar to adult. You see the remarkable difference in the definition of hypotension and septic shock. This is very, very low limit. You might see why. We'll come to that when we discuss the management. This just only to alert you to the differences in the definitions. Okay, it is important that I am sure many of you, when you face a patient with shock and the family around you, they are asking, Dr. Ali, Dr. Sultan, etc., what is my patient going to survive? The answer needs good informations and background in the pathophysiology of the shock. And you know where is your patient, at what stage of shock. That is critical for the answer. Say, for example, the patient who is having prolonged capillary fill time, tachycardic, tachypneic, and so on, he is in shock, but the blood pressure is maintained. This is what's called compensated shock, or in the WHO definition, circulatory impairment. Here they have a very high rate of success in the management, and the mortality is very low. But unfortunately, if the patient did not receive the appropriate management at that moment, he will or she will progress to decompensated shock. That means the patient is having now already decreased blood pressure, and in this case, the mortality is higher. Let me to go back a little bit here about the why they have compensated shock. Why they have, say for example, the first, to be honest, I really love the pathophysiology because,
السلام
and
عليكم
this
ورحمة
one,
الله وبركاته
my
دكتور.
usual advice to the
أنا أرسلت
student.
لك هذا الرابط لكي تشوف الأخوة في منظمة الأطباء.
Okay, so the point here is that knowing the pathophysiology, you retain more the informations and you know more the clinical features, and definitely you target the appropriate management. Why there is compensation though the patient is in shock, but the blood pressure is maintained? The reason is here. See, the green line is the cardiac output. Cardiac output start to drop early, dropping, and the blood pressure is maintained normal to a certain limit, then it drops suddenly. And we will come to that serious, because that is very serious in pediatric. This compensatory mechanism, it cheat you if you didn't attend and you don't know this phase, how to deal with it, and to detect the shock early. Why the blood pressure is maintained? though the cardiac output is low because of the endogenous catecholaminerase release, adrenaline. These cause peripheral vasoconstriction, and that increase the vascular resistance. That will maintain the blood pressure for some time. But if there is no intervention by treating the underlying cause, then the problem will continue and he will progress to hypotension and the organ perfusion failure. And then if there is no treatment, even at this stage, where the patient is hypotensive, then the patient will progress to irreversible shock, in which the multi-organ failure develop, and then, as you know, mortality more than 90% in these conditions. In developed country, what about if it is in other country where there is multi-organ failure and there is no other supportive surfaces? It's important again to know another important part in the pathophysiology about the progression pathway in at cellular level. Inadequate perfusion to the tissues, the end result or the bottom line is cell death because of destruction and dysfunction of the cell function. So it goes to different steps: cell hypoxia, energy deficit, and that will result to anaerobic metabolism, in which the lactic acid is accumulating. And there is different ways, from the metabolic acidosis, cell membrane dysfunction, intracellular lysosome release, digestive enzymes, toxic substances enter circulation, capillary endothelial damage, etc. And these metabolic acidoses as well contribute to the vasoconstriction, failure to capillary sphincters, and peripheral pooling of blood. So why I focused here? Because it has important implication for the prediction of death. The higher the lactic acid level in the lab work, the higher the mortality will be, and we'll come to certain studies in that point. So here is the lactate significant, the critical threshold 2.2, and there is different studies that showed, for example, in the PICU, the risk is 6.7. That means almost 7 times higher risk in the first 3 hours if the lactate more than 5. And after 12 hours, almost 12.5 higher risk, which is really a huge difference compared to the normal level of lactate. In the postnatal, more than 3.38, which is the cutoff, it indicates early onset clinical sepsis. And 5 millimole was the predictor for mortality in the neonatal sepsis. Here you see how important the difference from 2 millimole to 4 millimole lactic acid. The sensitivity is 20% and the specificity 92%. So very sensitive. The higher the level of the lactate, the higher the better sensitivity to detect the progression to the mortality. Sometimes one reading it might not be enough, of course, unless it is very sky high. Just only weeks back, we have seen patient with lactic acid of 17. So that's really clearly very, very abnormal. However, sometimes if you have a lower reading, then a serial measurement is important, because it will show you how is the progression of the patient status. Diagnostic accuracy improved by combining other parameters. Yeah, that means not only lactate, but you need to combine other factors. For example, there is a study, 100 children, 50 with sepsis and 50 with non-sepsis as a retrospective. And the area in the curve showed that lactate, the risk is 0.76, albumin alone 0.69. But if you take the lactate to the albumin ratio, it reached 2.85. And that means the lactate albumin ratio is a robust marker for evaluating children with sepsis. So if you have the lactate level and the albumin, you take the ratio more than 0.85 and higher is significant. So how to classify the shock that can identify the underlying cause and it guide the management? Starting from very obvious cause, which is trauma. And we know they have multiple causes for mortality, for shock in trauma patients. Bleeding, it could be hypovolemic shock because of huge bleeding, pneumothorax, tamponade, myocardial injury, neurogenic, all of these can cause shock in trauma patient. But the patient will come to you clearly, there is history of trauma, so you are approaching the trauma patient. And as you know, now there are trauma team, and primarily, of course, they are a surgeon to deal with these different problems in that particular patients. And then it progressed to different causes. Let us to go one by one. So, for example, the most common in pediatric is the fluid loss. It's not only because of gastroenteritis, which is the most common, but as well DKA, they come severely dehydrated with severe acidosis due to different etiologies. But here, they lost a lot of fluid. Third space in bowel obstruction. They have capillary leak, distended abdomen. It is not because of gas, because of leak of fluid to the abdomen, and that will cause shock. And GI bleeding and others. Patient who is having fever or hypothermia in pediatric, and he is immunocompromised, the first thing to come to your mind is septic shock, and of course other or toxic picture related to whether the like staph toxic shock syndrome, or sometimes even a toxin. You have to consider that. Abnormal cardiac exam, like whatever finding that you find when you examine the cardiovascular system. If the baby is within the first 3 weeks, here you think of the duct-dependent congenital heart disease. In this case, of course, the management is different. We'll come to that. And maybe the patient have arrhythmias, myocarditis, cardiomyopathy, poisoning, non-traumatic tamponade, and MISC, as you know, which is known multisystem inflammatory syndrome that appeared after COVID. And maybe the patient has exposure to allergen for the first time, not known to be allergic to certain foods or materials. Sometimes if the patient is known to be allergic to peanuts or others, family will say, yeah, once he took that one and he is known to have allergy, he developed these symptoms. So it's straightforward, you'll go for the management. But sometimes not known. But the sudden appearance of symptoms, as it will be explained later, it indicates that maybe you are dealing with a patient with anaphylaxis. Non-traumatic pneumothorax, massive pulmonary embolism, adrenal insufficiency, all these need to be thought about as the cause of shock, because the management is directed according to the underlying cause. So to classify as a 3 groups, all of these etiologies, it come into three domains, you can see. Volume problem, and the volume either absolute deficiency in the intravascular volume due to multiple causes, or there is redistribution of the volume like in septic shock. Vasodilatation, the volume distributed to the blood vessels, and the circulatory system to the tissues diminished. So that is the big group, and that's the most common. Or pump failure, in which the heart as a pump is failing, or the vessels, the blood vessels abnormality, either severe vasoconstriction causing ischemia to the tissues, and that of course could be different causes, but that's not very common. The more common is the vasodilatation, and the vasodilatation, that means the blood is distributed to the tissues, and it's not anymore effective to cause perfusion. So it is tank, dynamo, and pipe. This is what usually I presented, very simple to the staff that consider the shock is like that. You have a pump, which is the heart, and you have the pipes, which are the blood vessels. Now, to treat this condition, you need to know which is the primary problem. Is it in the pump or is it in the blood vessels? So that is important, and we'll come to that in the different scenarios in the management of shock. Okay, so very, very important to have a systematic assessment. The more you are systematic in assessing the patient, the more you pick up the problems existing. Otherwise, if it is jumping from here and there, you will miss problems. And of course, if you miss clinical finding, you will not direct the management to the appropriate site. So start with the visual look. You assess the patient from the start, what they call a visual triage, by the pediatric assessment triangle, by the appearance, work of breathing, circulation, the color of the skin, that all can give you a general hint. And to be honest, when they triage the patient in the emergency department, the first thing is a very senior nurse standing in the desk and at the entrance of the emergency, and from the lock, she will either activate the code or she will divert the patient to the vital signs and, of course, to the other pathway. Important to see if there are stridor. If the patient is in shock and he's having stridor, maybe you are dealing with angioedema or anaphylaxis in which there is upper airway edema. In the same time, it causes the shock. Wheezing, crackles, so maybe you are dealing with either cardiogenic that affect the lung or as well anaphylaxis. Now, in the circulation, you assess, of course, the rhythm, the weak, is it bounding, the sides. The sides here is very important in pediatric. The younger the baby, the more you have to check for the limb pulses and to check for any radiofemoral delay. Because, you know, the baby is a newest to this world, so maybe you didn't know what's going on. Maybe there is congenital anomalies. Maybe there is severe coarctation of aorta. Maybe there is interrupted aortic arch, and so on. So if that signs detected and the patient is in shock, you know that we are dealing with duct-dependent congenital heart disease, so I will target the treatment accordingly. Why I placed the blood pressure with the red background, I think the answer is clear. From the slide that has explained the stages of shock, the compensated and the decompensated. So if the blood pressure is low, now we are in a more serious situation in children. By the way, the difference in adult is great. Say if an adult, sometimes they start with low blood pressure. Low blood pressure will call everyone, nurses, physicians, come and help. But unfortunately for pediatric, because of this strong compensatory mechanism, they are in shock. And if there is no clever physician to detect, like, oh, the patient is tachycardic, tachypneic, what's the cause? And then he go and check capillary fill time. And then he check the pulses. Oh, this patient is really in compensated shock, so I have to act and treat this problem. This way, drop in blood pressure in pediatric is an ominous sign, and it is really very important to act super quickly. Level unconsciousness is known because the perfusion to the brain, and that is obvious sign of shock. And you expose the whole baby clothes and check. Maybe the color is cyanose or pale and so on, all of these. And the temperature is hot, is hypothermic. Hypothermia in pediatric is important. The younger the baby, the more important that hypothermia, if detected, can indicate a problem. And if the patient is having purpura, which is non-blanching rash, it indicates the patient is having maybe septic shock. And if the patient is having urticaria, it might indicate that the patient is having, with the presence of shock, is anaphylactic shock. The principles of management, it comes here. It's very important that when we assess, do the rapid initial assessment, which the ABC, and we classify the shock in the same time. Assess, start immediate management. Sometimes the management started non-specific, but it have to be really very important to try to detect what's the underlying cause, because further you need to target the management according to the underlying cause. So the principle here that you need to restore the imbalance. What we said before, that the shock is an imbalance between the oxygen delivery and the oxygen consumption. Now you need to improve the oxygen delivery, minimize the consumption, and optimize cardiac output. Maybe you will say, how can I minimize oxygen consumption? How can I go to the cells? Yeah, we cannot go to the cells, of course. However, in a well-equipped setting, the patient, if he's in severe shock, and you think that you have to go to this stage, then you need to intubate the child. You need to paralyze the child. You need to sedate him. And if there is fever, you need to kill the fever. All of these can decrease the oxygen consumption, because you know when you intubate the child and the ventilator work for him or for her, you are almost serving 30% of the oxygen supply and the nutrients. Instead of going to the respiratory muscles, it goes to the rest of the tissues. It is very important to have time sensitive, very quick, and teamwork. You know, it's a complicated case. We have to work by more than one person to make the treatment faster. How to restore the imbalance from formula to remember? To be honest, my own terminology for this, I call it the formula of life. You will see, I'm sure you might agree with me why it is in that way. You know the stroke volume. What the stroke volume, I usually prefer to have interactive discussion, but unfortunately in these remote presentations, sometimes it takes the time more than the benefit. This is why I will go ahead and just explain. So stroke volume, it means how much blood is pumped from the heart per 1 beat. So what determines this stroke volume, this amount of blood that is ejected from the left ventricle to the tissues in every beat, is the preload, yani how much intravascular volume existing. Is it too much, too little, or normal, and the cause something else? Contractility of the heart, and of course the afterload. Now the afterload, sometimes maybe it's not focused on by some people or clinicians. Afterload means if the patient is having peripheral vasoconstriction, cold extremities, prolonged capillary refill time, this will increase the load on the heart. And that definitely, with the management, it have to be dealt with. If you multiply the stroke volume, which is the one, ejection of that certain amount of blood from the heart per beat, multiplying by the heart rate, this will give us, as you all know, the cardiac output. Now, another important part of the component, this is the cardiovascular component, right? Now, another part is the saturation multiplied by hemoglobin by a factor 1.34. This will give us what is called arterial oxygen content. And this is related, as you say, to the hemoglobin and the respiratory function. So this intimate relationship between the two systems, in addition to the hemoglobin, is very important for the oxygen delivery. So if you multiply the cardiac output by the arterial content, it gives you the oxygen delivery. So why this formula is important to keep it in your mind during your management of the patient in the hospital? Because it gives you the different categories of etiologies, what could be the cause, as well as it directs you to the major area for the management, which one to tackle. Say, for example, are we aware that patient is in shock and the hemoglobin is 10? And for example, Dr. Abdullah will tell you that please give him backed RBCs. You will say, why shall I give backed RBCs for a patient whose hemoglobin is 10 gram per deciliter? I will tell you that the patient is in shock, and to improve the oxygen delivery, you need to have a higher cars to carry more oxygen to the tissues. So you multiply the saturation by the hemoglobin and so on. So this is just only an example of how important to have a comprehensive understanding of this part. Of course, different way to how to evaluate each component. For example, stroke volume, the pulse volume, organ perfusion can help to detect. If you have the bedside ultrasound in the emergency, you can do the POCUS. And of course, ECG is available, chest X-ray and CBC, you can assess all of these. And sometimes the blood pressure, as stated before, it is cardiac output multiplied stroke volume, give the map. And this can be assessed by the temperature and capillary fill time. So let us to go to the initial management. You start with the resuscitation. Then you go to the specific treatment and continuous monitoring. Now, the critical point here, which sometimes is not taken seriously, is the reassessment. Every intervention, when you give the patient whether bolus fluid, you started in drops, whatever the intervention you are giving, either respiratory, cardiovascular, or whatever, you need to reassess the efficacy of your step. If that, because maybe the improvement is not that what you are looking for. Maybe you need to go more. Maybe you have exceeded, and so on. Because the variation and the response from one patient to the other is, as you all know, is great. So if the patient is not responding, then you see maybe he's improving, and or the trend of improvement. You say the patient heart rate was 170. Now after the initial bolus, it come to be 140. Oh, good. There is a trend of lower heart rate, which means the patient is responding. Capillary fill time was 6 seconds. Now it is 4 seconds. That you will be happy that you are in the right direction, and so on. Or there is no improvement, or the patient is worsening. Then you have to rethink, is the patient, am I dealing with that particular diagnosis, or there is a different diagnosis to redirect the management? Sometimes the no improvement, sometimes or worsening is due to overshooting, either in the fluid or in the inotropes, if you started inotropes. And definitely you think about rare diagnosis. If the patient is not improving, or despite of your management, is the patient have pneumothorax, tamponade, massive pulmonary embolism, adrenal insufficiency, hypothyroidism, and all of these. Okay, when you start with the recitation, you start, as stated initially, that in a systematic manner, the ABC management. There is variation here. Please focus on me. In the abundant resource abundant setting, a resource limited setting, an area where is the intensive care, effective intensive care setup, area there is no intensive care setup. We'll come, of course, in detail on that, but this is a brief. And the airway and resource abundant setting, where the ICU is clear, there is no problem, no restrictions. And in breathing, again, there is no restriction in the resource abundant. But in the resource limited, there is a concern about intubating a child. So what are the alternative ways to give the patient oxygen? Try with neurourethral mask, try high flow nasal cannula, bubble CPAP, LMA with bag mask ventilation, of course, and for how long you will continue, that's different issues. And it depends where you are, and do you have a higher, I mean, there is a way that you can transfer the patient to a higher center for care and so on. That's something else, but we're talking about the principles of the variation between these two setup. There is a point here. When you take care of the airway and breathing, sometimes we jump immediately to intubate the child, and we have the setting is enabling us to do the intubation and the mechanical ventilation. This is not really, in the presence of shock, is a safe behavior. What is advised here is resuscitate, then intubate. There is a lot of mortalities happen just in the peri-intubation period because of the hemodynamic compromise. Because when you intubate the child and you do ambu bag, you are making positive pressure in the intrathoracic area, and the patient is already in shock. So the cardiac output from the right ventricle to the lungs is blocked, because the venous return from the systemic circulation to the right atrium, then to the right ventricle, to the lungs diminished. Because you know the CVB, the venous pressure that drive the blood to come back from the tissues to the right atrium, 4 to 5 millimeters mercury. That means really very minimal pressure. So if you are pushing air to the lungs, you increase the intrathoracic pressure, and that will diminish the venous return, and the patient die within that procedure. And it's sometimes in trauma, it reaches to 28% mortality. That means, or cardiac arrest during the intubation in these scenarios. So please take care that if you are able to, and you have the setting to intubate the child, try to manage the shock as much as you can, then proceed, even if you start inotropes to improve the shock state. Then if needed later, the intubation, you are in a safe level. Okay, so let's see a patient مثلا whether trauma or spontaneous pneumothorax, and you find out there is a tracheal deviation. The first thing is to do is the decompression immediately, and to avoid as much as you can with pressure ventilation, because this will aggravate the pneumothorax, unless very important or critical to intubate. We have mentioned to the duct-dependent congenital heart disease, like in which you see here, that is another important alert to my colleagues. The patient came with saturation of say, for example, 60, 65, and so on, and then you start the management, then the saturation by your intervention reach to 80. You will say, no, 80 is still low saturation. I need to have more than 90 saturation, more than 92, more than 94. That is not helpful in this situation, because in drug-dependent heart disease in shock, the more you oxygenate the child, the more there will be higher perfusion to the lung, the more heart failure. So here it have to be limited, the oxygen supply, and the saturation have to be within this range. It is not, I mean, it was placed, aimed for that purpose. And then, of course, you give 10 ml per kg, reassess, any thrombosis is needed. And the mainstay treatment in duct-dependent congenital heart disease is the prostaglandin, because you are trying to reopen the duct to improve the circulation. By the time the patient will be admitted to the pediatric cardiac care unit, and they will do the intervention needed for that patient. Patient with flu, I mean, he's having like, you can say, muffled heart sounds, and you suspect like there is a pericardial tamponade. So then you start to give like a fluid, inotropes, and you need to elevate the legs, avoid post-pressure ventilation as needed. And of course, there needs some expertise under ultrasound guidance to do pericardiocentesis or surgical drainage if the surgeon around, cardiothoracic surgeon, and definitely the thoracostomy later is needed. Maybe rarely you will find patients who have central venous catheter or malignancy to have signs of shock due to pulmonary embolism. Here it is very subtle signs compared to the other very clear signs of shock. And here the TBA is part of the treatment, or via catheter and surgical embolectomy, and sometimes they need ECMO. These four conditions is what is the different or the major causes of obstructive shock. Further to the management of the different types of shock, we start with the cardiogenic shock here. You know, in the cardiogenic shock, the primary problem is the myocardial contractility, in which there is decreased stroke volume and cardiac output, and that will increase the left ventricle and diastolic pressure, and that will lead to pulmonary edema. Now, that decreased in stroke volume and cardiac output as well, it causes hypoxia, and hypoxia as well is caused by pulmonary edema. So at the end, they will have decreased coronary perfusion pressure, and of course, with the hypotension, it further worsen the condition. At the end, there will be ischemia. Now, ischemia as a vicious circle, it decreases the myocardial contractility. And the other pathway, that there is activation of renin-angiotensin, aldosterone system, and autonomic nervous system. This will induce more catecholamines, cause vasoconstriction, increase heart rate and contractility. That will increase the myocardial work and oxygen demand. And that, again, if that is limited supply, the contractility will be impaired as well. The neurogenic shock, the primary cause of neurogenic shock, as you all know, is a transection of the sympathetic supply from the spinal cord, and any lesion of the spinal cord above T7 to T6, it can cause disruption to the sympathetic supply. And the blood vessels are controlled only by sympathetic nervous system. That means if there is the spinal cord trauma at that level, no more catecholamines released. That means there will be vasodilatation, and they will be, of course, decreased myocardial contractility because the endogenous catecholamines release is diminished. You might see how there is very important alert here. If the patient came to the trauma and he's in shock, and there is no obvious bleeding to explain that shock, then keep it in your mind that it could be a neurogenic shock. Now, what are the particular clinical findings in neurogenic shock that you need to alert you? The first is that the patient is not tachycardic. At the same time, the blood pressure is low. So is it a usual case? The answer definitely is not, because any drop in the blood pressure, or even only in the compensated shock drop in the cardiac output, the heart rate will go up. That's the normal physiology. But if this is not existing in the scenario, that means there is no way for the compensatory mechanism to work, there is no catecholamine release, which means the sympathetic supply has been affected in the spinal cord injury. So this is the neurogenic shock in terms of pathology. So you give fluids because the vasodilatation, it needs fluid, and as well as maybe you will start even norepinephrine and phenylephrine, because the primary problem now is the peripheral vasodilatation. So you need to make vasoconstriction, and because the heart is normal, it's only redistribution of the fluid. So bradycardia can be improved as well with atropine, and adequate spinal cord perfusion is important to have good or restore the perfusion to the affected part in the spinal cord. Anaphylactic shock, I think it is as a common, to be honest, and that will help colleagues from different areas where they are working. You worked around 20 years in the PICU. I couldn't remember that I have seen patient with anaphylaxis. I said, well, I'm just reading in the textbook. Now, I'm working supervising pediatric emergency. Almost every day, we see anaphylaxis. And of course, rarely to have anaphylactic shock, because the family, they came already, when there is initial anaphylaxis, they have the EpiPen, the epinephrine, that they can give it at home with the earliest sign of anaphylaxis. So they came relatively stable, and we just continue the management. And fortunately, no serious patients so far happened. So what's happening in anaphylaxis? It is inflammatory mediators release because of the allergic reaction. It increases capillary permeability, fluid leak into the interstitial space, and vasodilatation as well. Not only leak of fluid to the interstitial space, but as well the vasodilatation, and that will lower the SVR, systemic vascular resistance. So vasodilatation, leak of fluid outside the blood vessels. These two important components can lead to shock if no immediate treatment. Sorry. Okay, so act fast. Death can occur within minutes. This is why the family, they have to be given the EpiPen to give it immediately with the appearance of any symptoms. Epinephrine IM, regardless severity, and this great, very strong evidence to support once you have detected it's an anaphylaxis, then you need to give the intramuscular epinephrine immediately. Maybe the patient responded, but again have relapsed, then definitely you need to give another IM intramuscular dose. But if you are giving first, second doses of boluses of epinephrine intramuscular, and the patient not responding well, or there is a recurrence, then you need to start epinephrine infusion, and that is grade 2C. Another alert about the approach of managing cold shock from warm shock. By the way, I mentioned earlier, compared to adult, the warm shock is more common. This is why they have lower blood pressure quickly. Here, because of compensated shock, compensation mechanism in pediatric is strong. Most of the time, the patient are in compensated shock. That means they have cold shock, which is the other name, and the SVR is high with poor contractility. In this case, epinephrine is the drug of choice because there is already peripheral vasoconstriction. We cannot start with a strong vasopressor from the start because already the blood vessels are constricted. So epinephrine will increase the contractility. You will say, okay, epinephrine as well, it can cause peripheral vasoconstriction. That's true, but with a lower dose, it is more effective in the myocardial contractility, but with a higher dose, it can cause vasoconstriction. But the priority here is to improve the contractility. And the opposite in the warm shock, in which the SVR, as a result, is low. Poor contractility, of course, it might be, but in the same time here, the norepinephrine is the preferred medication to start with because the objective is to have peripheral vasoconstriction by the norepinephrine. What's the rule? Where the rules of dobutamine and milrinone? By the way, here, if the patient is having hypotension, it is not advisable to start bilirubin because it causes peripheral vasodilatation and that worsens the shock. However, if you start, for example, the patient in norepinephrine or epinephrine and the blood pressure improved, but you have peripheral vasoconstriction, cold extremities, then you might start touch of one of them to have little peripheral vasodilatation to improve the perfusion, but the blood pressure is already normalized or in a better shape. And resource-dependent hemodynamic support for septic and hypovolemic shock. Say, for example, here we have the different type of shocks. There is no difference, like cardiogenic, traumatic, obstructive, no difference in the management, whether in a resource-dependent or resource-limited setup. But it makes a difference in the septic and hypovolemic. We'll come to that. Why it differs? First, in resource-limited setting, the referral systems, pre-hospital care, financial limitations, retrieval system, etc., are really delayed, so they came late. Second, malnutrition, anemia, malaria, other infectious disease, lower vaccination rate. These can complicate again the management. And the third factor is that you don't have a trained staff to take care for critically ill patient, either in the emergency or in the ICU. That's really trained in pediatric CV, I mean critically ill pediatric patients. Nurse to patient ratio, even if it exists, say ICU with ideally a sick patient with organ failure, at least 1-to-1. That means one nurse to one patient. And some of the patient is complicated with multi-organ failure. Definitely more than one nurse have to take care of that patient. Central catheter, arterial access, vasoactive infusions, these are all available or not available? Here, if it is not available, then the problem can worsen definitely the outcome of the management. Worldwide, most shock are cared for in resource-limited setting, and I'm sure you still remember the first slide of the epidemiology, how it is condensed in third world countries. But the problem is that, the recommendation that we are reading and we are teaching and all of these, it comes from a high resource countries. Till just only a decade ago, where there was a good study from one of the African countries, tell the people that please stop, didn't give us a lot of fluid for patient in area where the resources are limited, because the outcome, it come worse and increase the mortality. And that may be the basis of the changes and the intervention of the WHO with these guidelines. Will come a little bit in detail within a minute. So is it an absolute hypovolemic shock or septic shock? Here where it, as stated, they might be at different. These are the most common types of shock in resource-limited countries. The question or the answer for this question, are we dealing, a patient who is in shock, is it hypovolemic or septic? What make a difference? What will be the make a difference if I know that this is shock is due to hypovolemia or a shock because of sepsis? I know both they would have hypovolemic status, whether absolute or relative. Relative in septic shock because peripheral vasodilatation, maldistribution of fluid, but in hypovolemia it's absolute loss of volume. The difference is here. Hypovolemia, usually if you give fluid, there will be no problem because you are replacing what is lost. But in septic shock, if you give more and more blindly a lot of fluid, there is an element of cardiogenic shock as well, because sepsis can affect the myocardium. And here where the problem can happen, and the patient will go to congestive heart failure, and then he might die from that reason rather than from sepsis. So to differentiate, of course, it's not absolute, but if you have a patient with having severe dehydration, there is history of thirsty and sunken eyes, maybe you are dealing more of severe dehydration. And if that's not existing and the patient is in shock, most likely septic, in addition to other differentiating parameters, as stated earlier, with the fever, hypothermia, and all the other supportive issues. We are talking about from the initial look to the patient, okay? Not after several hours and you differentiate and you have a workup. But the key for these, which sometimes difficult to decide in what direction to go, is to monitor the patient, monitor the response, and observe for complications. That is very, very important concept. So the initial fluid management in these conditions is that you see a resource-limited setting, the physiological status, as we stated earlier by the definitions, circulatory impairment, one or two signs of what has been called extremities, capillary fill time more than 3 seconds, and rapid pulse. Here, you didn't need to give any fluid bolus. If you are sure that you didn't have backup for respiratory support by mechanical ventilation with a good setup, here giving a fluid, but just only because there is prolonged capillary fill time or cold extremities, etc., the risk is much higher, or the risk is much higher than the benefit. So this is why the recommendation is not to give fluid bolus. Now, in septic shock, and in this patient, and we have stated that either hypotension in that severe lower level, or the three findings are there. Here you give 10 to 20 ml per kg over 30 seconds. That means I can give 10 ml per kg over 30 minutes. You will find later in the other setup, I will give it even faster. Here, there is a slow infusion. So, or 20 ml over 60 minutes, but the preference is to give 10 ml per kg, observe, and then assess. Are you able to give the second, or the patient already developed complications? If the patient is having severe malnutrition, severe wasting, here again you need to manage your fluid bolus. Just only 10 to 15 ml over 1 hour, not 30 minutes even. You see how careful you need to be with. And if he is remaining in shock, then you add 10 ml per kg for lactate ringer or alflu or novasaline over 30 minutes at that grade 2C, but later on. Now, resource abundant, as usual, as we are reading in the textbook. In compensated shock, you will give 10 to 20 ml per kg over 5 to 20 minutes, and that's grade 2C. And decompensated shock, you give even up to 20 ml per kg over 5 to 10 minutes. Though the recommendation even now to give 10 ml per kg, 10 ml per kg, and then repeat every 5 to 10 minutes, 5 to 10 minutes, and then you reassess and say, did you reach to the target by improving the vitals and the shock improved, or no, you are exceeding, and if there is a problem, then you need to stop. That is without severe anemia, because you see in these countries, unfortunately, the thing is too complicated. So with anemia, there is still further precautions we need to take it. The first thing is that to give blood, because the patient is in shock and he's having severe anemia, and if the fluid can cause more problems in this patient. So if you are able to get whole blood, 20 ml per kg, within this short period, that's great. If no whole blood, you give back to RBCs, ready, you will cross-match and very quickly, and they will support you in the blood bank. Okay, you will give 10 ml per kg back to RBCs over 4 hours. If not within 30 minutes, you will give this blood in the presence of severe anemia, and severe anemia definition here less than 6 grams per deciliter. Or it might be even less than 5 in malaria endemic region, like in our tropical parts of the country. So if there is severe anemia less than 6 or less than 5 in malaria region, then you have to give priority for the blood transfusion. If not within 30 minutes and the patient, he is in shock, then you are allowed to give 10 ml per kg over 1 hour. You see, compared to the other in the other areas where there's ICU care, you can give it over 5 to 20 minutes. Okay, continuing the initial management of the shock. Here about the vasopressors. And the vasopressors, if the patient is having like circulatory impairment, where there is no ICU care, you didn't need to even to start vasopressors. And septic shock, often limited to adrenaline. That means noradrenaline, there is no window. So adrenaline, if available, you can start. And even the indication here that you might even start a little bit earlier because you don't give fluid. Resource abundant setting, here the recommendation is known that compensated shock, decompensated shock, you can use it in any level of shock if the fluid alone is not enough and is not adequate. But make sure that you fill the tank, as I have mentioned before in the definition of shock. If you are starting epinephrine or norepinephrine according to the type of shock, and the tank is not full, I mean, there is no enough intravascular volume. You are just burning the pipes because the tank is empty. So definitely that is not a good option. So make sure that the patient has received adequate volume, and then you start the epinephrine or norepinephrine. Vascular access is another issue, of course. The maximum that you can get in the resource-limited countries, if the IV is not accessible, you cannot get IV access, then intraosseous have to be available, and it is life-saving. In the resource-abundant country, they have a facility even to proceed intraosseous immediately, of course. If the peripheral IV access is limited or cannot be obtained, then you go to the central venous catheter. And that help even for further monitoring of the CVV and other benefits. Even there is some variation in the initial antimicrobial therapy, primarily for the addition of anti-malaria in the endemic area. However, the antibiotics is the same, of course, on both setup. Okay, let us to summarize some points here in certain issue. The fluid have to be based on the ideal weight, or not on the, if the patient is obese, then that you should not take it on the ideal body weight rather than from the actual weight. The patient, most of the time, the shock resolved, perfusion improved, there is no more fluid boluses. I mean, that you stop any more fluid to be given to the patient. Consider maintenance fluid, monitor for shock recurrence because, you know, it has a very dynamic status. Maybe they needed inotropes, so you started inotropes or vasopressors. And if not improving after all of these, even in the inotrope, then you call it catechism resistant shock, and then you need to start hydrocortisone. Prefer to take hydrocortisone level before, but if not, you just proceed to steroids. And of course, be ICU further. Many might ask what type of fluid to give in the management of shock. Shall I give ringer lactate, or shall I give BBF, plasma protein fraction? Shall I give normal saline? Crystalloid rather than colloid is preferred for two reasons. Number one is that the outcome is similar in both, but added to that, to the benefit of crystalloid, that it is readily available and less expensive. So you don't take care of that. I mean, it's no major problem with these. You just continue in the fluid that you have. Of course, ringer lactate available is better than normal saline in terms of both crystalloids, but you don't need to start with BBF. So sepsis is a dynamic process and it's evolving. So definitely you have to keep an eye on the patient for any progression. You might say, okay, I didn't know the weight of the patient, that he came from a rural area, and I don't know. If the parent know the weight, maybe that means a long time, maybe they forget. So for sure, the parent know the age of the child, and you can calculate the weight from this formula as it is indicated in the APLS. Where are we in sepsis detection tools and strategies? This is just a brief pointing out before closing. You see, it started in the pediatric application of sepsis criteria evolution. In 2005, it started the systemic respiratory respiratory syndrome about the criteria and how to detect the sepsis and all of these. And then later, 2024, just only published last year, 2025, the phonics sepsis score. But that it focused on life-threatening organ dysfunction. However, the difference, they are both a good framework for sepsis. Better to have these criteria with you when you manage a patient with a sepsis and deal with a patient with sepsis and septic shock. Detect these, the SIRS, systemic response syndrome, detect mild illness. Early warning screening, it's considered early warning screening for sepsis. But it's not good for identifying risk for poor prognosis. And the opposite for this phonics sepsis score, in which it identified the highest risk of mortality, but less early. It cannot detect good the sepsis early, similar to the SIRS. A scoring system with a balance between early recognition and mortality prediction is lacking so far. Meanwhile, both can be utilized with the clinical judgment, careful and repeated assessment. The new criteria, which is I just mentioned, the Vonix sepsis score, it focused in the the effort that they produced. This score really, it was a great effort. They have international survey, they have done systematic review, they analyzed more than 3 million pediatric healthcare encounters, and they built up out of this as a consensus in a formed process. So what they say, the patient if the patient is suspected to have infection, plus 2 of these criteria, like respiratory compromise, cardiovascular compromise, coagulation problems, neurological systems, then yeah, the patient is having a high risk of mortality out of this with this picture. But if the patient having sepsis plus at least 1 cardiovascular, then the patient is in a septic shock, and of course the mortality is higher. So to take home messages out of this talk is that first, systematic assessment is essential for timely detection and management of shock, and identifying the cause of shock during the initial management. You don't forget what's the cause of shock. Please identify why the patient is in shock, so you target the management appropriately. Keep in mind the oxygen delivery formula components for the comprehensive support, and we stated that the cardiac output component as well as the arterial oxygen content components, and pay attention to the concern in shock management in both resource limited and resource abundant setting. By the way, when resource limiting setting and resource abundant setting, it is not only applied to like poor countries and rich countries. Maybe both sitting present in the same country. Depends on where the patient in that country. And SIRS criteria for early detection of sepsis and Phoenix score for mortality prediction. أخيرا، من المعاناة يولد التميز، وبالصبر والثقة والعون من الله تتحقق الأمنيات. طيب الله أوقاتكم.
شكرا جزيلا يا دكتور، شكرا على هذه المحاضرة القيمة، أكيد الكل استفاد منها. طبعا باب الأسئلة بيكون اللي يحب يرفع يده زي الدكتور محمد قد رفع يده، أو يكتب السؤال والدكتور ناصر بيقرأ عادي. يمكن الأسئلة الأخوة اللي ما يشتيش يتكلم بالإنجليزي يمكن يطرح سؤاله باللغة العربية والدكتور بيتكلم معاه بما هو يعرفه يعني. فالدكتور محمد تفضل. دكتور محمد الحميري،
حياكم
أنا
الله
عامل لك أنميوت.
حياكم الله دكتور ناصر، وشكرا للجنة المنظمة الدكتور مهنا والآخرين أيضا. تحية أيضا للضيوف الكرام، وعلى رأسهم الأستاذ الدكتور نائب وزير الصحة، أستاذنا ومعلمنا. أنا عندي طبعا الدكتور محمد الحميري cardiac anesthesia consultant, program director of the cardiac anesthesia fellowship in Al-Ahsa region. My only notice about the cardiogenic shock or using of inotropes, you mentioned that the Merinon and dovitamin we are using if there is a peripheral vasoconstriction. Actually, we are keeping these 2 drugs for if there is a right ventricle failure or impairment. So we can use it instead of epinephrine with the peripheral vasoconstrictor, the like vasopressin. For example, we are using this combination, Merinon and norepinephrine, in case of cardiogenic shock with a specific right ventricle failure or pulmonary hypertension. This is number 1. Number 2, about the intubation. They have changed this in the American Heart Association. Instead of ABC, they changed that you have to start by compression, and the compression itself, it will entrain the the air. So this is help to regain the circulation. Instead to waste time for preparation of intubation position and stops compression. All of this, once the patient start to regain that there is a heart rate and also there is a pulse, that okay, you have to intubate. Otherwise, the bag valve mask is enough. And the other things about the fluid resuscitation, and I think for the training or for the trainee, that a simple thing that you have to start for any patient in septic shock, in the anaphylactic shock and hemorrhagic shock, whatever, okay, you have to start with the fluids, okay, until the circulation resumed or there is hepatic enlargement, and this is so easily developed, and you can check it every 5 minutes like that. Other things that, mashallah, Doctor, you covered everything very well. Also, the last thing that in this all of these lectures, that if there is any lecture about that TOT or training of trainer, that it will be very helpful for also the doctors and also for the training themselves. Thank you so much.
Thank you very much, Dr. Muhammad. Just only, and that's a very valuable comments, and really I benefit for that comments. As regard to the CPR, of course, this is, beyond the scope of this lecture, because we talk only on the shock before the arrest. So, in the compression and the CPR, as you know, is a different subject. Just only, thank you.
شكرا دكتور محمد. دكتورة إيمان، تفضلي دكتورة إيمان، فاتح المايك ليكي. إيمان باصادق. أنا عامل لك أنميوت. طيب
Yes, I did
حتى
unmute.
تفتحها دكتور. أيوة.
Okay. Thank you so much for this comprehensive and illustrative lecture. I think you have tried to simplify it as possible. Just some comments. I think we actually base our classification on shock by 4 components, whether being hypovolemic, cardiogenic, or distributive or obstructive. And the first important thing we always tell to our students and postgraduates, before you come and examine any pediatric patient, taking history or doing a full physical examination, check for the vital signs, because a child is there in front of you. You can never know what state he is in. So if you are sure that the vital signs are stabilized, then you can proceed. Then once you know the diagnosis of the patient, you should go for the prognosis. Everything has been stabilized. You've made your provisional diagnosis. Think of the prognosis. What complications you should anticipate on this patient? And besides of the signs that you have mentioned, besides looking for the cold extremities, weak or thready pulse, and for the capillary filling time, I think oliguria is also another manifestation we check for. And for the late signs, it's very important to check for the disturbance of consciousness. And thank you very much once again.
Yeah, thank you very much, Dr. Iman. Yeah, for sure, the organ perfusion, urine output, they need to put the catheters so they know sometimes if they are, it needs some time, but the catheter can help in assessing early. And of course, the liver consciousness of the patient really, with the management, he start to regain consciousness, and that's another important, for sure, sign, definitely.
شكرا. في دكتور هنا في سؤال ويقول لك what is the difference between neurogenic shock and spinal shock؟ تقريبا إنه واحد اسمه حسام. يمكن تشوفه بالسؤال اللي موجود في الشات. What is the difference between neurogenic shock and spinal shock؟
Personally, I didn't come to the terminology spinal, but I guess it's the same, because trauma in the spine, it causes neurogenic shock. Most probably that's what's meant.
اوكي، شكرا دكتور. تقريبا نحن وصلنا للنهاية، الساعة 4 تماما. هناك العديد من الدكاترة معنا، الزملاء هنا، الدكتور شوف البروف حسني القوشعي، الدكتور محمد الحميري، الدكتور عبد الله العصيمي، البروف خالد الصريمي، برضه زميلنا الدكتور مهند في إدارة البرامج، والدكتورة سماح. أشكركم جميعا، وأحب أن أشكر الدكتور عبد الله دحان والدكتور عبد الغني، وأخواننا، لا أنسى أخواننا في إدارة البرامج الذين جهزوا هذه البرامج، والأخوة في الإدارة، اللجنة الإعلامية ولجنة السكرتارية، الذين وقفوا وراء هذا البرنامج واشتغلوا بجد. يعني لسنا وحدنا، ولكن هناك الكثير خلف هذا البرنامج. فإذا كان أي سؤال ما لم نختم البرنامج وننتظر محاضرة الغد مع المهندس عبد الناصر اليوسفي. هي محاضرة بتكون عن ضمان الجودة وإدارة المخاطر لإدارة المستشفيات، فيا ريت تكونوا معنا غدا. دكتور عبد الله دحان، كلمة ختامية.
أنا أقول الحقيقة أنا كنت سعيد جدا قبل المحاضرة، والآن أقول أنا سعيد جدا جدا بعد الاستماع للمحاضرة القيمة التي قدمها أخي العزيز الدكتور ناصر. وسعيد جدا أيضا بالملاحظات التي أو التساؤلات أو الإضافات التي طرحت من الأخوين الدكتور محمد الحميري والدكتورة إيمان. حقيقة أشعر بأنها ستكون بإذن الله بادرة خير في الإضافة للتدريب للأطباء المقيمين، ولأن مستواها أنا أعتقد مستوى المحاضرة هي أعلى من مستوى طلبة الطب، خصوصا في المراحل ما قبل السريرية. لذلك ما أتمنى حقيقة من المقيمين المشاركين في هذه الدورة والحاضرين في هذه المحاضرة تحديدا أن يستفيدوا من التقسيم الرائع الذي قام به الدكتور ناصر في كيفية التعامل مع حالات الشوك أو الصدمة، وبالذات في المناطق ذات الإمكانيات المحدودة، لأنه قسمها إلى قسمين، في يعني مناطق تمتلك إمكانيات عالية ومناطق تمتلك إمكانيات محدودة. وأعتقد أننا في اليمن ربما في غالب مستشفياتنا ندخل في إطار التقسيم أو الفئة الثانية. شكرا جزيلا دكتور ناصر مرة أخرى، وأتمنى أن تستمر فقرات هذا البرنامج على مدى الأسابيع القادمة بنفس الروح وبنفس القيمة العلمية والمهنية العالية. والسلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله. جزاك الله خير
شكرا
دكتور، بارك
دكتور.
الله فيك.
شكرا دكتور
شكرا
ناصر.
لك.
طبعا الدكاترة هنا العشرة تقريبا ما قصروا، وحاولوا قدر المستطاع أن يبذلوا جهدهم، وإن شاء الله تكون محاضرات قادمة مميزة، ولكم جزيل الشكر. طبعا كما تحدثنا مع الدكتور عبد الله، هناك برامج تدريبية. طبعا المحاضرة الواحدة لا تكفي أنه واحد يخرج فاهم، فتكون برامج، هناك برامج تخصصية منبثقة في طب الأطفال، في النساء والولادة، في التخدير. إن شاء الله بتكون برامج تدريبية يتم التجهيز لها لاحقا. شكرا لكم جميعا، وجزاكم الله خير، وإن شاء الله نلتقي يوم غد. البرنامج بيكون كل سبت وحد، كل سبت وحد حتى 10 مايو.
بالتوفيق إن
شكرا
شاء
وجزاكم
الله.
الله خير، ونلتقي غدا.
في أمان الله. مع
مع السلام
السلامة.
عليكم.
السلام.
سلام. الأخوة في الإدارة يمكن تغلقوا التسجيل، وجزاكم الله خير. طبعا الأخوة اللي يسألوا في التحضير